So, sir, we are live.
So, good evening, everyone. On behalf of Pfizer Oncology Commercial Team, I am Sushavan. Welcome you all in this today's scientific meeting. Today, we have a meeting that is a GU Live meeting, and our topic is first-line maintenance in the treatment of the metastatic urothelial carcinoma from clinical trial to clinical practice. We are very privileged to have three young medical oncologists among us as a faculty member for today's meeting. And they will discuss on recent updates on the urothelial cancer. So let me introduce them. So today we have Dr. Tamajit Choudhury with us. Sir is head of the department and senior consultant medical oncologist, Meherbai Tata Memorial Hospital, Jamshedpur. Dr. Tamajit has done his DM Medical Oncology degree from that prestigious institute, Kidwai Memorial Institute of Oncology, with a gold medal. He is associated with many national and international clinical trials as a co-investigator and investigator. He has participated in many national and international conferences as faculty. Dr. Tamajit Choudhury has also many publications in national and international peer-reviewed journal. Welcome you, sir, in today's meeting. Next, our faculty is Dr. Kumar Mondol. Sir is a consultant medical oncologist of AMRI Hospital, Kolkata. Dr. Tanmay has done his DM medical oncology from the Makkah of Oncology of India, that is Tata Medical Center, Mumbai, and Sir has many publications in the national and international peer-reviewed journals. He has been PI and co-investigator of many national and international multi-center studies. And Dr. Tanmay has also associated in many national and international conferences as faculty. Sir has a very good training in bone marrow transplant. He is a trained transplanter, and in a previous hospital also, Sir has done many bone marrow transplant. Welcome you, sir, in today's meeting. Our next and last faculty for today's meeting is Dr. Amit Sharma. Sir is a consultant medical oncologist of HCG Panda Cancer Center, Kotak. He has been participated in many clinical trials, and Dr. Sharma is also participated in many national conferences as faculty. He has many publications in peer-reviewed journals. Welcome you, sir, in today's meeting. So, I stop sharing. Sir, now the stage is with you, Dr. Choudhury. You can start the discussion.
Sir, you want me to share the slides?
Yes, absolutely. Thank you, Sushavan, for your kind words. And I think am I audible clearly? So welcome, Dr. Tanmay and Dr. Amit. Hope I am audible clearly, Sushavan?
Yes, sir, loud and clear.
Okay, perfect. Thank you. So thanks for this platform and rare discussions we are going to have today. So we have a lot of discussions. Usually we have a lot of discussions on breast cancer, lung cancer, and other targeted therapies. But rarely we discussed nowadays regarding the updates of urothelial carcinoma or bladder cancer per se. So it's a deadly disease in advanced metastatic stages. If treated with chemotherapy, particularly with platinum-based doublet or quadruplet regimens, usually the median survival is not more than 12 to 14 months. Toxicity is much. The issue is after 4 to 8 cycles, there is usually progression, and or you can't continue this regimen due to cumulative toxicity of platinum and non-platinum agents. So there is a real need for new therapies or first-line maintenance therapies in advanced metastatic setting. And what is the current data and current recommendation and guidelines, that is what we are going to discuss today. And at the same time, we'll try to take Dr. Tanmay and Dr. Amit's opinion also. There are a lot of issues during the practice because nowadays it is a problem of plenty, like in metastatic RCC in first line and second line setting, we have more than 5-6 category 1 recommendations. And similarly in bladder cancer also, or urothelial carcinoma also, in all lines, there are more than one category 1 or category 2 recommendations. So depending on the clinical situations, how you choose our therapy, a base therapy for a particular patient, for a particular clinical situation, that we have a lot of practical discussions with Dr. Tanmay and Dr. Amit regarding their practice and their usual preferences of different approved regimens. So optimizing treatment options in advanced urothelial carcinoma from clinical trial from bench to bedside, that is the topic. So as you know that we have 2 or 3 decades old platinum doublets or quadruplets in the form of platin gemcitabine. Platin can be both cisplatin and carboplatin, or the dose dense or normal 3-weekly MVAC regimen. But again, the issues are toxicity, issues are fast progression within first 6 to 8 months of treatment initiation. So what is the best way forward? That is what we're going to discuss today. Next. So this is my disclaimer slide. Next. Yeah. So basically we'll discuss with a focused discussion towards avelumab, which is the first line maintenance drug, the only immunotherapy drug which has shown any survival benefit in first line maintenance therapy in advanced metastatic urothelial carcinoma after the initial 4 to 6 cycle of platinum based chemotherapy. Next. Yeah. So by definition, urothelial carcinomas basically can origin from the urothelial cells of urinary bladder, urethra, ureter, and renal pelvis. Usually 90% of them are from urinary bladder and usually high grade in nature. The issue is there is a law of diminishing returns. That means in advanced metastatic setting, if you start therapy with platinum-based doublet or really MVAC regimen, then after 6 to 8 months, the first line patients will have a progressive disease, and then you have to start the second line therapy. Usually before the era of immunotherapy or before the approval of second line immunotherapy agents, or even after the approval of immunotherapy agents also, only 1/3 patients practically in real world setting receives any form of active second line therapy over and above base supportive care. So this slide is very important in showing that even from all parts of our world, the data has been collected, and the cumulative data is showing the very similar picture in different parts of the world, that there is a law of diminishing return. Only 35 to 40% of the patients actually receive any second line therapy, active therapy, either in the form of chemotherapy or immunotherapy. And that again highlights the need for improvement of the first line therapeutic options or post first line chemotherapy, improved maintenance therapy options, just to improve and maintain the good quality of life for the patients, so that more patients will be able to receive second line therapy in active terms. Next. So regarding choosing the therapy, how to choose the first line agents, either chemotherapy only or chemo-immuno combo or immuno only, predominantly patients are classified based on their eligibility to receive cisplatin, which is a cisplatin eligible group. And the second is cisplatin ineligible but eligible for carboplatin. That means platin eligible but cisplatin ineligible. And third is ineligible for any sort of platinum. So depending on this criteria, usually the agents are to be chosen as per the current recommendations. So it's a very soft criteria. There is no robust criteria for cisplatin eligibility, depending on different practical concerns and different the baseline comorbidities and patient's organ functions. Usually the decision has to be taken along with the patient's performance status also. So usually during my practice, usually what we see that most of the patients of advanced metastatic disease, 50%, almost 50% patients are cisplatin ineligible, and almost 25% of patients are platinum ineligible and fit for only base supportive care. So among platinum eligible, 75% patients, half of the patients are cisplatin eligible, half of the patients are not cisplatin eligible. Next. So the platinum-based chemotherapy eligibility, how to choose the eligibility there, although it's a soft criteria, but usually for platinum ineligible patients are those with a poor performance status, ECOG performance status more than 3, creatinine clearance below 30 ml per minute, more than equal to grade 3 peripheral neuropathy at baseline, NOIHA heart failure more than class 3 at baseline, or ECOG PS2 with creatinine clearance of less than 30. So simply patients are fit for carboplatin but not fit for cisplatin. That means cisplatin ineligible but fit for platinum recipient. So these are the patients who are having a creatinine clearance of less than 60 but more than 30 ml per minute, and NYHA heart failure class 2 or class 3. So this is the group where carboplatin can be offered, but cisplatin is usually not offered. And I usually don't do a P-tone audiometry check at baseline for a advanced bladder cancer, because usually we give 4 to 6 cycle of platinum-based chemotherapy, and cumulative cisplatin dose is not more than 400 mg per meter square. But unless patients are having more than grade 2 baseline sensory neural deficit or a history of sensory neural deficit, that time I usually do. So on this regard, I want to take opinion from other my colleagues, Dr. Tanmay and Dr. Amit. What is their usual criteria for choosing the patient for platinum eligibility or cisplatin eligibility, and whether they routinely do P-tone audiometry before starting chemotherapy in advanced metastatic urinary bladder cancer? Dr. Tanmay, your opinion.
So no, the routine criteria for choosing for cisplatin eligibility are, yes, these are the things which are mentioned: the performance status, the GFR, the peripheral neuropathy at baseline. If the patients are diabetic at baseline, who have higher chances of developing neuropathy. So these are the common criteria which we generally do for seeing the cisplatin eligibility. And yes, it's true that we at least don't do routine audiometry for these patients who are planned for a gemcitabine plus cisplatin based chemotherapy. We generally don't do a routine audiometry.
Thank you. Dr. Amit?
I think yeah, this is I also passed out from Kedwai, in fact, and in Kedwai we used to do P-tone audiometry over there, and as you told us, more than grade 2 auditory defect, that then sometimes we may think about carboplatin. But let me tell you very frankly that carboplatin is not as easy as we thought about it. Because when you combine carboplatin with gemcitabine, but the chances of bone marrow suppression is pretty much. Okay.
Thrombocytopenia, yeah.
Yeah, thrombocytopenia, especially the
Agreed.
platelet count. So it's not, I think it's, what I personally feel is I would look into the most important, only the creatinine clearance. Okay, so less than 30, okay. But even less than 40, I will be a little bit careful with cisplatin. Okay, and next thing is performance status wise, surely, but again, more than 2, definitely we tend to use carboplatin. But again, we have to think about there would be chances of thrombocytopenia in such patients. So we have to be very closely monitor these patients when we are starting these patients on gemcitabine or plus carboplatin. Because I actually see a lot of patients developing suppression.
Agreed. Thank you.
Yeah. And in old age patients, I mean, sometimes, suppose if your patient, these patients are metastatic urinary bladder, these are just generally old patients, 70, 75, in that range, 60, 70s. So these patients maybe have sensory neural deafness. So maybe our cumulative dose thing, we have to be a little careful.
Yes, perfect.
Yeah.
Next slide. Yeah, so what is the OS that we usually observe with chemotherapy in our practices? Median OS not more than 12 to 14 months. I think that is agreeable for a good performance status patient who can take 6 to 8 cycle of platin Gemcit backbone or 6 to 8 cycle of dose dense impact. The survival can be in the range of 14 to 15 months, median overall survival. But for an unfit patient, for an cisplatin ineligible, when you use carboplatin particularly, and there is a cumulative toxicity like discussed by Dr. Amit, a lot of hematological toxicities can be there. So which usually preclude us from giving more than 4 to 6 cycle. That time the survival can be in the range of 10 to 12 months also. So what we theoretically see that the median overall survival, although in cross-trial comparisons, is slightly higher with cisplatin backbone in comparison to the carboplatin backbone. But always there are some selection bias in this aspect, because usually cisplatin fit patients are having a good PS, good organ function. Next. Yeah, so usually the disease control rate is in the range of 70 to 80% with first line platinum based chemotherapy. The overall response rate is in the range of 50 to 60%. only around half of the patient, about 40 to 50% of the patient received second line therapy, usually with platinum-based backbone on particularly cisplatin gemcitabine based first line palliative chemotherapy. The first line median PFS or progression-free survival is usually 8 to 9 months. And so median survival is not more than 12 to 15 months. Next. So there are 3 different type of approaches which are practically possible for managing and how to sequencing therapies in advanced metastatic urothelial carcinomas. The 3 approaches are: number 1 is wait and watch approach, where you give a first line chemotherapy, usually platinum based doublet, and after 6 cycles you wait there for the disease progression, and when disease progression is there or detectable, then you initiate second line of therapy. The second one is a continuous maintenance. It's mainly tried in the form of chemoimmuno induction therapy for 4 to 6 cycles, and after 4 to 6 cycles, usually chemotherapy stopped and immunotherapy continuously given as a maintenance therapy. And switch maintenance option is also there, where you give initially chemotherapy, and after 4 to 6 cycle of chemotherapy, you give totally a new immunotherapy which is not given during the chemo induction. So we are going to discuss all these options in detail and what are the data available at this moment. Next. The first one is the tried and tested method, which was the standard of care half decade earlier before the publication of this avelumab data, that wait and watch approach. The first line with the platinum-based chemotherapy, the response rate is around 40 to 50%, disease control at 50 to 80%, median OS 15 months. Next. And always cisplatin-based chemotherapies give slightly higher median overall survival than carotid-based regimens. Next. So is there a role of immuno-oncology drugs in the first line? Obviously, the answer is yes, and we are going to discuss in which setting and in which drug. Next. So the immuno-oncology drugs or immunotherapy drugs, either PD-1 or PD-L1 inhibitors, can be added in a chemo induction backbone in 2 different ways. One is in continuous maintenance, where you give the immunotherapy drug along with chemotherapy initially for induction phase and then continue it as a maintenance, or it can be given as a switch maintenance. So for a continuous maintenance, there are few trials. So the IMvigor 130 and Keynote 361, both are the immuno combo. There is one arm which is immuno combo. The first IMvigor 130 has an atezolizumab plus platinum-based doublet arm for 4 to 6 cycle, and then atezolizumab has been continued. Although chemo only or atezolizumab only arm was also there. It is a 1:1 randomization, so 3 arm study. Very similar design, Keynote 361 also. There is an immuno monotherapy arm, there is a chemo monotherapy arm, but the experimental arm is chemo immuno combo with pembro plus platinum backbone. After 4 to 6 cycle, you continue pembro as a maintenance therapy. But both these trials have failed to show the primary endpoint positive results. They are failed for an OS data, and Keynote 361 failed for PFS data also, although the initial interim data of IMvigor 130 median PFS is still positive, and final OS data is immature and going to be presented in next year. The Danube is basically a chemo-free backbone arm trial. It's basically again a 3-arm, it's again a 3-arm trial. The experimental arm was durvalumab plus tremelimumab. It's an immuno combo. So anti-CTLA4 inhibitor plus anti-PD-L1 inhibitor. There is 2 other arms. One is durvalumab monotherapy and one is chemo monotherapy. Again, this trial has failed for both the co-primary endpoints for OS and PFS, both in PD-L1 positive and negative population. Next. So next slide. So as discussed that the primary endpoint, which was the overall population OS, and in PD-L1 positive population, both this Keynote 361 and IMvigor study have failed to show any positive results. Next. And there are minor improvements in the next slide. Minor improvements in the median PFS in the IMvigor 130, although it's an interim data, and final mature data of the PFS and OS is still awaited, and Keynote 361 is failed for the median PFS also. Next. And Danube again a 3-arm trial, durvalumab monotherapy, durva plus tremelimumab for 4 doses and followed by durva maintenance and chemotherapy on the arm. Again, you can see clearly the Kaplan-Meier curves. There is a clear-cut crossover. One crossover at the very beginning within 3 months, and the second crossover is at 12 months, and there is absolutely no difference in overall survival. So this is also a failed data. Next. So the next third approach is a switch maintenance. So here what we do is usually give 4 to 6 cycle of platinum-based chemotherapy. It can be either a cisplatin gemcitabine or a carboplatin gemcitabine or dose-dense MPAC regimen, and followed by patients without any disease progression. That means patients who achieve a CR, PR or stable disease. Switch maintenance started in the form of avelumab every 2 weekly 10 mg per kg dose till the progression or cumulative toxicity which is unacceptable. So initially, before the design and the initiation of this Javelin Bladder 100 study, which is a first-line avelumab maintenance study, initially there is a positive data from pembrolizumab with a similar design, but it was a phase 2 small data. The OS was not significant for this phase 2 pembrolizumab data, but PFS significantly improved in the overall population with the addition of pembrolizumab switch maintenance after platinum-based chemotherapy. So that paved the path of designing this phase 3 randomized control trial, the Javelin Bladder 100, which used is almost very similar design, but a different switch maintenance drug, which is avelumab, which is a PD-L1 inhibitor. Next. So overall, wait and watch. We know what is the means policies and what are the drugs to be offered for a continuous maintenance. As of now, all the 3 trials have failed to show the co-primary endpoint positive result. For a switch maintenance, which the trial we are going to discuss with the Javelin Bladder 100 for the avelumab switch maintenance, it is the only trial till date which has shown an overall survival benefit both in the overall population as well as the PD-L1 positive population in first-line maintenance of the bladder cancer. Next. So this is again almost the repetition, 3 different approaches, and only the Javelin study has shown a survival benefit, which is a positive outcome for a switch maintenance. Next. So overall maintenance therapy introduces a treatment approach for patients who have a response or stable disease after the initiation of platinum-based chemotherapy. And the policy we have already discussed that initially patient has to be platinum eligible, either cisplatin or carboplatin eligible, give 4 to 6 cycle of drug, and without any progressive disease, start maintenance therapy, preferably within 4 to 10 weeks of completion of last cycle of chemotherapy, and then you continue it till progression. When progression, you stop the immunotherapy maintenance and start the second line therapy options. Next. So there is a clear-cut biologic rationale of combining or using this switch maintenance. And so there are mainly 3 reasons. So number 1, to prolong the response. So the response which is achieved with the first-line platinum-based chemotherapy, that has to be continued or longitudinally prolonged with the use of maintenance immunotherapy. The second is maintain the quality of life. So as in the very first slide of this presentation, we have discussed that there is a law of diminishing return. In the real world scenario, only 30 to 35% patients actually receive any active form of second line therapy, either chemotherapy or immunotherapy over and above standard of means base supportive care. So if you can maintain the quality of life of the patient during the first line therapy, that can potentially increase the percentage of the patients who receive any active form of second line therapy. That is also again a concept of using immunotherapy as a maintenance. And third one is there is a synergism of previous chemotherapy that we are going to discuss in subsequent slides. Next. So Javelin Bladder 100, it's basically a multi-center randomized phase 3 trial, almost 700 patients enrolled. And 2 arms are after the completion of the 4 to 6 cycle of platinum-based doublet, the patients has been randomized, provided there is no progression of the disease, randomized to base supportive care versus avelumab plus base supportive care. 1:1 randomization, and the experimental have continued till progression or till unacceptable cumulative toxicity of the immunotherapy drug. Next. So this, I think we have already discussed. The primary endpoints are 2. There are 2 primary endpoints, 4 primary endpoints. Number 1 is the overall survival in the all randomized patients, and number 2 is overall survival in the PD-L1 positive population. Secondary endpoints were PFS and overall response rate, time to response duration, disease control, and safety and tolerability, as well as patient-reported outcomes. So overall, 700 patients enrolled and randomized, and 350 in each arm with 1:1 randomization. Next. So as we have discussed, there is clear-cut biologic rationale of combining or using this switch immunotherapy approach. So there is a priming effect of prior platinum-based doublet chemotherapy. As you all know, that chemotherapy, what it does, it causes cytoreduction. It causes reduction of the tumor cell volume by direct cell killing or DNA damaging. And there is as well as additional effect in the form of reduction of immunosuppressive cells. There is reduction of the myeloid-derived stromal cells and regulatory T cells, which are actually immunosuppressive. So, and avelumab as a maintenance therapy, as we all know, that it's a highly selective IgG1 human anti-PD-L1 antibody. It causes the blocking of anti-PD-L1. So there is a blocking of interaction between PD-1 and PD-L1, which subsequently removes the suppression of PD-L1 on the cytotoxic CD8 T cells. So in that way, both prior chemotherapy actually causes the priming of increased sensitivity or long duration of sensitivity to the maintenance immunotherapy. Next. So this is the baseline demographic parameters. 68 years is the median age. Majority were male, 76%. The good performance score. Around 55% have visceral disease. And regarding the first line chemotherapy regimen, which has been offered before the randomization of this study, around 52% patients received gemcitabine cisplatin, another 40% gem carbo, and only 6% and 6% patient received actually switch platinum agents, means some cycles gem carbo and some cycles gemcitabine cisplatin. So regarding the primary endpoints, next slide. So two primary endpoints, one is overall survival in the overall population, and second one is overall survival in the PD-L1 positive population. So regarding the overall population OS, as the initial data cutoff, which was 21st of October 2019, there was very significant benefit with an hazard ratio of 0.69. The median overall survival was 21.4 months versus 14.3 months. And for a long-term analysis with a data cutoff date of 4th June 2021, that is further improved. So the control arm having a median overall survival of 15 months versus 23.8 months. Again, the hazard ratio was much significant in the range of 0.6. Next. So for a PD-L1 positive population, another co-primary endpoint. In this trial, around 51% patients overall having a PD-L1 positive status, which was equally distributed in both arms. So again, the overall survival was very much significant in the long-term analysis of almost 31 months versus 18.5 months as a data cutoff date of 4th June 2021. Next. And this forest plot clearly showing that all the pre-decided subgroups, keeping in mind the response to the prior chemotherapy, CRPR or standard or stable disease, receive of prior platinum stratification, cisplatin versus carboplatin, the creatinine clearance, the visceral versus non-visceral disease, and regarding the different geographic and ethnical origins, almost all pre-decided subgroups have shown benefit favoring the avelumab. Next. So regarding the secondary endpoints like the PFS, next. Again, just like OS, for the initial analysis and long-term analysis, both have shown clear-cut benefit favoring the avelumab arm. So initial data analysis on 21st of October 2019 data cutoff date, the median PFS was 2 months versus 3.7 months. At the longer follow-up, it was 2 months versus 5.5 months. Next. So this is a practical issue that whether to perform PD-L1 testing before the starting of immunotherapy maintenance, avelumab maintenance in advanced urothelial carcinoma or not. So, and there is a continuous upgradation of recommendations regarding this PD-L1 testing to be done or not, first line or second line or before starting maintenance therapy. So if you can see the recent recommendations regarding the NCCN or ESMO, the standard international guidelines, that for a cisplatin eligible patient, there is absolutely no requirement for doing any PD-L1 testing before starting immunotherapy maintenance. For cisplatin ineligible patient, if you plan for a gem carbo based chemotherapy backbone followed by avelumab maintenance, then also there is no requirement. And for this subgroup, which patients are cisplatin ineligible but actually carboplatin eligible, then you have theoretically the option of using atezolizumab and pembrolizumab monotherapy. But recent guidelines actually removed pembrolizumab from this criteria also. So as per the recent recommendation, pembrolizumab in first line monotherapy only indication is platinum ineligibility. For cisplatin eligible patients, pembrolizumab can't be used as per recent guidelines. Atezolizumab, that indication is maintained, but only for a PD-L1 positive population. So if you can look carefully, the ESMO guidelines for cisplatin ineligible, and so atezo can be only used for a PD-L1 positive patient. Otherwise, for platinum ineligible patients not eligible for cisplatin or carboplatin, both atezo and pembro monotherapy can be used irrespective of PD-L1 status because there is no other option. So to me, for a first line setting, the PD-L1 testing is indicated only in the scenario of cisplatin ineligible if we plan to give atezolizumab monotherapy. And moreover, there are a lot of issues regarding the testing and cutoff of PD-L1 because all these three different drugs, the different platforms are there. For pembrolizumab, usually for advanced urothelial carcinoma, the platform is a TACO22C3 platform. Cutoff limit is different. For an atezolizumab, it's an Ventana SP142 platform. Cutoff is 5%. For an avelumab, the platform is again Ventana, but the antibody is SP263 and the cutoff is 25%. So the issues are different because if we use different platform and you can't use the other different drug which is not recommended for the platform. So on this regard, this is a very complicated topic. So what is our common practice on this regard? I want to take opinion from my friends and colleagues, Dr. Amit and Dr. Tanmay. So Dr. Amit, your opinion, usually you do during your practice PD-L1 testing before first line maintenance or before second line in any scenario, or regarding these platforms, what is your opinion?
Look, if we look carefully, as you tell us in this particular trial, the overall population, irrespective of PD-L1 status, get benefited from the maintenance therapy. But if I'm sitting in the OPD and patient is actually asking me what is my predictive responses, then maybe I will predict it much better if I do PD-L1, because we know that if the PD-L1 is higher, then the survival rates are better. As high there's, so it depends ki how I'm talking to my patient at that point of time. Otherwise, as per guidelines, there is no requirement of doing PD-L1 as per say to starting avelumab maintenance therapy. If I am actually thinking about atezolizumab, then only maybe I will require PD-L1 status, that to be with SP142. In other lung trial, if you remember, there was a trial that which shows that the SP263 and 22C3 and SP142 is actually giving kind of very
concordance
results. So yes, that can be taken with little bit of caution. If we have already done, say, most common test which we used to do is 22C3, I guess, most of the times. Most of the labs are generally actually do 263, SP263. Most of the labs here in Bhubaneswar. So yes, maybe this is probably the most common kit which is being used around India. So we can take it, no doubt, but as per right now, what data which we are getting, clear-cut data with survival benefit, irrespective of PD-L1 status, we can straight away go ahead with avelumab. Why we want to go with this thing? I mean, PD-L1, unless and until we are sitting in the OPD and patient wants to ask us, I am spending so much amount of money for the maintenance therapy. You tell me how much predictive benefit I may get. Then maybe I will tend to do PD-L1 status in that case.
It's fully agreed. So what is shown in this slide and what is highlighted again during the presentations, all ESMO and other international conference presentations, that the overall population, the data is positive for a PD-L1 positive population, which is 51% of the overall population. Again, the data is positive. But if you look carefully, the PD-L1 negative subgroup, then the hazard ratio is clearly not as encouraging as the PD-L1 positive subgroup. So
we just look at the median OS itself, 31 months is there in PD-L1 positive patients.
Yes.
So
again,
that's clear-cut showing for 31 months versus 23 months. 10 months itself, the difference.
Yes. So what we are going to say that for the incremental benefit for a PD-L1 positive population with an addition of avelumab is much higher than in the PD-L1 negative population. What is more focused and more highlighted that the overall population and PD-L1 positive population. But if you look carefully, the PD-L1 negative population, although it's just statistically significant, but data is not so encouraging. So what is highlighted by Dr. Amit, I fully agree with him that if the patient is asking for that, what is the probability of having a good response, or can you predict that? Probably we are more confident as a clinician for using this drug, which is a very costly drug in the PD-L1 positive population. So, but as per guideline, as per recommendation, as per medical legal issues, if you can use in overall population, there is absolutely no issue.
No need, no
So,
need.
yeah, no need. Thank you. Dr. Tanmay, your opinion? What you usually do in your practice?
I think what Dr. Abhishek said is perfectly right, that actually we don't do it. But yes, if anyone is asking and if we want to prognosticate more for those patients, then only we can do it. But actually in real world, I also don't do the PD-L1 testing for before starting avelumab or any immunotherapy in a bladder cancer.
Yes. Thank you. Thank you. Next slide. So now we'll further take this data that what are the different subpopulation and what is the hazard ratio of OS benefit of different pre-decided subgroup analysis of this Javelin study. So one of the stratification endpoint was the response to prior chemotherapy before the randomization of this study. The response can be CR, PR or stable disease. So whether there is any difference depending on the pre-existing chemotherapy response before the starting of avelumab. Next. So this subgroup analysis again clearly showing that irrespective of the response, whether it's a complete response or partial response or stable disease, the benefit is maintained favoring avelumab. But if you look carefully, the hazard ratio is 0.72 and 0.7 for a partial response and complete responder. But for a stable disease, the hazard ratio is 0.84. And again, there is some margin of the Kaplan-Meier curves at about 30 months. So again, the predictiveness of the overall survival impact, a positive overall survival impact of addition of this avelumab is much more if the patient having a good response with prior chemotherapy, platinum-based chemotherapy. Next. So similarly for in PFS also, it's irrespective of the pre-existing chemotherapy response, the benefit is maintained. But and here also for the stable disease also the good response is maintained. Next. Next question is regarding the prior chemotherapy backbone, platinum backbone. So gemcitabine cisplatin versus gemcitabine carboplatin based backbone, whether there is any difference in the avelumab overall survival data. Next. So again, for an OS and PFS, if you compare the gemcitabine cisplatin versus gemcitabine carboplatin, absolutely no difference. Graphs are very much identical. Hazard ratios are very much identical. So the take-home message is overall survival and progression-free survival benefit with avelumab in first-line maintenance occurred irrespective of the first-line chemotherapy backbone or more specifically at the platinum backbone. Next. Third is the duration of chemotherapy, or the more specifically the number of cycles, 4 versus 6 cycles, because as a trial design, any number of cycles between 4 to 6 was allowed. So the question we are trying to answer is whether there is an incremental benefit of giving more chemotherapy. So 4 cycle versus 6 cycle. Next. So again, the subgroup analysis, the Kaplan-Meier are showing that there is no difference actually. So anywhere between 4 to 6 cycle you can give, but although for 5 cycle the benefit is less pronounced, but these are all statistical analysis. And if you can look carefully, the number of patients, the sample size for a 5 cycles data subgroup is very minimal. So this type of, because this trial is not adequately powered to give the answer to all these small subgroups, that is the answer. But in between, what we can say broadly is there is no difference. So again, I want to take opinion from my colleagues, Dr. Amit and Dr. Tanmay, that what is your usual practice if the patient is not affordable for immunotherapy, suppose, and there is no cumulative toxicity of this drug, and you are planning for an wait and watch after the first line chemotherapy and planning for a drug holiday. So what is your common approach? There is no cumulative toxicity, good tolerance. So you go for 6 cycle or you go beyond 6 cycle for a carboplatin based regimen, or you stop after 4 cycle. What is your common practice, Dr. Tanmay? Dr. Tanmay? Tanmay, are you here?
Yes, I am here. I couldn't get the question. Just can you just?
Yeah, I am repeating. It's just, am I audible clearly?
Yes.
Okay. So question is, patient is not affordable for avelumab, and so there is no cumulative toxicity. So you are planning for an wait and watch, and after the first line chemotherapy, you are planning for a drug holiday before the starting the second line of chemotherapy. So what is your common practice? You go up to 6 cycle for a platinum-based, for a cisplatin-based regimen, or you can stop if the patient achieve a good response. After 4 cycle, you usually stop if there is no cumulative toxicity. The second part of the question is, for a carboplatin-based regimen, means usually you go beyond 6 cycle if there is a good response after the 4 cycles.
Okay, so no, for cisplatin based, generally we go up to, for either cisplatin or carboplatin, I generally give up to 6 cycles if the patient is not affording for, or if we plan for a wait and watch after that. Generally
Okay.
6 cycles, but with cisplatin we have some issues after, even after 4 cycles also we might keep the chemotherapy on hold if the patient has a good response to this.
Okay, Dr. Amit.
I personally like to customize my treatment for my patient, such kind of a situation. For example, if patient is not, as you tell in your question, that patient is not affordable for immunotherapy. So my whole fundamentals will go back to the stage 4 patient, how we treat. I will give 3 or 4 chemotherapy cycles, and then I will see the PET-CT scan. If patient is responding, I will go for the further 3 more cycles. Okay, and then I will take it from there. Okay, if patient is continue to having responses, then probably maybe I won't give any further probably cisplatin. Maybe this is not proved in any trial, but maybe I can give single agent gemcitabine for some maintenance, because there is no trial. But as we know, we cannot leave the patient, or patient is willing to go for maintenance. If not, I will give for drug holiday after 6 cycles, and keep him in close follow-up. As I know that patient is going to recur. There is almost 80 to 90% chances that patient will come back to me with recurrence within a month, maybe in the next PET scan. I will tell him to come in after 3 months for the next PET scan after drug holiday, and I can bet he will have some disease. This is the kind of disease, metastatic urinary bladder is this. But if I took the question in a different way, suppose if we use this particular trial for use of immunotherapy, then what 4 or 6 cycles? What cycles? As we know, the results of this trial is showing that as good tumor reduction we does, the better we get the results. So why not go back to our basics? Do the PET scan after 3 or 4 cycles, see how much reduction we have done. If I have done enough reduction, we stop over there and start maintenance therapy, immunotherapy after that. If we have not done enough reduction, a patient has maybe stable disease, we can go for another 3 cycles and now see if patient has achieved better reduction. Then we can go ahead with maintenance immunotherapy after 4 or 6 weeks. So maybe a little bit of customization, because we don't know in both the scenarios when we want to give immunotherapy that how many cycles are sufficient, 4 or 6. So go back to the basics of stage 4, how we manage. Do the PET scan after 3 or 4 cycles, see the response, and take it up from there.
Yeah, agreed. So basically individualization of therapy depending on the performance status, cumulative toxicity, and the affordability, and the next plan, whether you are planning maintenance or not. And again, I fully agree with you that if there is a good response after 4 cycle as per the radiological assessment, but there is cumulative toxicity, you can't continue the platinum after 4 to 6 cycle, there is always good to continue gemcitabine for few more cycles to maintain that response if the patient is not affordable for immunotherapy maintenance. Fully agreed. Although it's not as per the recommended guidelines.
As per the guidelines.
Yeah. Thank you. So next. So the next subgroup analysis is depending on the interval between the last cycle of chemotherapy and the initiation of immunotherapy maintenance. So as per the trial design and enrollment, the criteria was anything between 4 to 10 cycles. 4 to 10 weeks is sufficient after the completion of large dose of chemotherapy. Next. So there is a subgroup analysis done regarding the OS and PFS of the patients who have been started with immunotherapy maintenance after completion of last cycle of chemotherapy between 4 to 6 weeks, 6 to 8 weeks, and 8 to 10 weeks. And again, the parameters are very identical in terms of hazard ratio and this Kaplan-Meier curves. So overall, it's acceptable if you give anything gap between 4 to 10 weeks. Although in real world scenario, sometimes we may give more than this gap also. Next is a very important part of this trial. So about 22% of this patient population out of 700 of the whole trial, 22% of the patients were Asians. So it is always good to know whether the outcome in Asian subgroup is different or same, as we know that there is a lot of pharmacogenomic differences between Caucasians and Asian population. Next. So overall, there was 21% of the population of the Asian patients in this trial, and the design remains almost same. Next. So the demographic parameters also remain. Next. Demographic parameters also remain very much identical. The median age was 69, predominantly males, good performance status patients, and almost half of the patients having PD-L1 positive results, and predominantly received gemcitabine cisplatin followed by gemcitabine carboplatin, and only very few patients received switch platinum agents, and a good response in the form of CRN or partial response, roughly around 68.5% with the pre-existing chemotherapy. Next. So the primary endpoint, which is the overall survival in the overall population, not the PDL1, but overall, including all population, again, very much significant. Overall survival is 28 months versus 18 months, median overall survival. Next. And the PFS regarding the median progression-free survival, it's again, median is 5.6 months versus 1.9 months. So it's very much similar to the overall population, including Asian and Caucasian patients and Australian patients. But if you look carefully, then in the overall population, the long-term data was roughly around 23 months versus 14 months for the overall population. PDL1 positive population having a median survival of roughly around 30 months. And here is the overall population having a median overall survival of 28 months. So in comparison to the overall population, Asian subpopulation showed a better result actually in terms of median overall survival. Next. So regarding the toxicity parameters, they're again almost very much similar to the overall reported data of this whole trial. Roughly around grade 3 toxicities in the avelumab arm was 50%, and base supportive care arm was 14.9%. Next. So in summary, the Asian subpopulation, the avelumab first-line maintenance treatment is a new standard of care in the Asian population, which showed a good primary endpoint data, positive data in terms of median overall survival, almost 28.7 months, and 22% reduction of the risk of death versus the control arm. So it's basically, and also there is prolongation of the line to next initiation of the next therapy, and with a good safety and tolerability parameter data. Next. Regarding the toxicity data of the whole trial, there is almost 47% grade 3-4 toxicities of the avelumab arm, 25% in the control arm, and only 2 patients drug-related or infusion-related death happened. One is due to sepsis, and other is due to ischemic stroke, which is happened long after the last infusion. So overall, there is discontinuation due to treatment-related toxicity in avelumab arm happens in roughly around 12% of the patients. Next. Regarding the immune-mediated side effects, roughly around 29% have patients having immune-mediated side effects in the avelumab arm, and out of them, only 7% are having a significant immune-mediated side effect in the form of grade 3, and luckily no patients had any grade 4 or grade 5 immune-mediated side effects. Next. And this is again a very important slide that there is a significant proportion of the patients who had continued this immunotherapy drug for more than 12 months. So roughly around 28% of the patients of this trial received avelumab for more than 12 months or more than 1 year as a maintenance therapy. So it is always good to look at the long-term toxicity data, whether there is any significant difference in the long-term toxicity, particularly after 1 year of immunotherapy in this trial. And absolutely there is not much different, no new safety signals appeared in the long-term follow-up. Next. So overall data-wise, next slide. Data-wise, around 47% of the patient received more than 6 months of this drug, 28% received more than 1 year, and 20% patient received more than 2 years of avelumab. Next. Now there is a very important subgroup with a long-term survival or expected survival. So for patients of this 28% of the patients of the whole trial who received more than 12 months of this avelumab, the median overall survival actually not achieved in the avelumab arm. And if you look at the median PFS, it's almost 26.7 months. That simply means the median OS of the whole population is equal to the median PFS of the population of 28% of the patients who have received this drug for more than 12 months. So again, this is a very good subpopulation. So patients without any progression of disease with the first 4 to 6 cycle of chemotherapy, and without any disease progression with 12 months of avelumab, they're going to survive probably more than 5 years. That we can say with confidence with this type of Kaplan-Meier curve. Next. So now we are going to discuss few important aspects regarding the second and subsequent line of therapy. So after the introduction of avelumab, when there is disease progression, obviously you have to introduce the second line therapy. The second line therapy can be a targeted drug in the form of an FGFR2 inhibitor or antibody drug conjugate, can be a conventional chemotherapy agent, or can be a different immunotherapy drug. Next. Next. So around 53% of the patients in the control arm or base supportive care arm of this Javelin study actually received any form of immunotherapy, either PD-L1 or PD-1 inhibitor in subsequent line of therapy. And then also this trial have showed a very significant overall survival benefit. So that is the beauty of this drug. And next. So regarding the second line therapy, whether patient received second line therapy, whether patient received PD-L1 inhibitor as a second line therapy, or there is a rechallenge of platinum-based chemo backbone, irrespective of that, there is no much difference of the overall survival curves in the avelumab arm. Next. So this is very well known that the second line treatment options as per the NCCN guidelines for post platinum-based chemotherapy backbone, the category 1 recommendation is pembrolizumab, but post checkpoint inhibitor, there is absolutely no category 1 second line indication. All are category 2A or 2B indication, and preferred agents are targeted therapies or rechallenge with platinum-based chemotherapies or a antibody drug conjugate in the form of enfortumab. Next. And this is different immunotherapy trials under in the first line setting or a first line maintenance setting in the form of Javelin, IMvigor, Keynote, and Danube study, which we have discussed. So regarding the subsequent therapies across trials, there is one thing very common, that is the rate of use of PD-L1 or PD-1 inhibitors in the form of immunotherapy in the base supportive care arm or control arm is very high, in the range of 30 to 47%. Next. Again, a very good summary slide that survival goes further with the right immuno-oncology drug at the right time. So first one is with the switch maintenance. You give a first 4 to 6 cycle of chemotherapy backbone, platinum-based backbone. You give a treatment-free interval of 4 to 10 weeks. You start a switch maintenance immunotherapy drug in the form of avelumab. So with the initial chemotherapy, there is a 3 to 5 months duration, and with median overall survival with avelumab is roughly around 24 months. So overall, the survival will be roughly around 30 to 35 months, which is even more for a PD-L1 positive population. That can be up to 36 months. So almost 3 years median overall survival with this approach. But none of the other approaches actually have shown the overall survival incremental benefit over and above our age-old chemotherapy backbone. So all this first line chemo-immuno combo followed by immunotherapy maintenance in the form of pembrolizumab or durvalumab or atezolizumab that provided median overall survival range in between 16 to 18 months. With an immuno combo in the Danube trial also, it's not the same, it's not different, and even lower, it's roughly around 15.1 months. Next. So this is the summary slide, that long-term follow-up of Javelin Bladder 100 study, more than 2 years of follow-up in all patients. It continued to show the prolonged overall survival PFS and with a very good survival curves. As you know that for an immunotherapy, the tail of the curve is very important. So what the curve looks like after 2 to 3 years of follow-up, what is the best population of 25 to 30% of the patients, the best subgroup population having the survival, that is probably the most important. And again, it is also highlighted from this trial that the patients who are going to have non-progressive disease after 12 months of avelumab is going to survive for more than probably 4 to 5 years. The overall survival of this population is still not achieved after the long-term follow-up. So the OS rate at 2 years were around 50% for the avelumab arm, and PFS rate roughly 23%. And long-term safety profile is very much consistent with the previous RTD reports. So basically, it's now the standard of care as per all approved guidelines. Next. So this is again a fill-up of my initial slide of this presentation, that for cisplatin eligible patients, probably cisplatin plus gemcitabine or the dose done MVAC 4 to 6 cycle followed by avelumab maintenance with the preferred choice first line. For cisplatin ineligible patient, gemcitabine carboplatin followed by avelumab maintenance, and for totally platinum ineligible, immunotherapy, immuno-oncology monotherapy, either pembro monotherapy or atezolizumab monotherapy is the only option in spite irrespective of the PD-L1 status. Next. So usually the second line for avelumab is also approved as a second line drug after the chemo platinum means platinum-based tablet or quadruplet chemotherapy for an wait and watch approach. And that time the dose is a fixed dose, which is 800 mg IV infusion over 60 minutes every 2 weekly. But for this Javelin study, the dose used was 10 milligram per kg. There is slight different, but otherwise usually the file strength is 200 mg per file. So for an 800 mg, you have to use 4 infusion files, single use files. Next. So I think that's all. If any, I think Dr. Tanmay has already left due to his busy schedule. And Dr. Amit, you want to say anything? You want to add anything to this presentation?
I think this is the only drug after so long. Is a practice-changing drug which came up in metastatic urinary bladder cancer. The graphs, survival curves are not only showing the tail and is significant, but also the early separation. When we compare with best supportive care, within 2 months, the curve started separating. So I think patients start getting benefit in survival rates as soon as 4 immunotherapies are over. So within 2 months. So this is something I feel very significant, because when I look at the other immunotherapy drugs, there is, the late separation of the curves. Whenever you look, it takes time. But this thing, I was seeing carefully all the curves. If you look back, there is a very early separation of the curves with best supportive care. Within 2 months, the curve starts separating. So this is very significant, which means more than 1 year is good, but at least more than 4 is also good enough to increase the survival rates of the patients. I'm not saying you give for cycles, but what I'm saying is this is something different with rest of the immunotherapy drugs, where curve separation occurs a little bit later, after 3 months, 4 months. So this is something I feel very interesting.
Fully agreed.
Yeah. And other thing which maybe I'm always worried about when maintenance therapy is given. This is a wonderful drug, no doubt about it. But 2 patients died during treatment of this patient. So maybe I would like to know who those 2 patients who died, who those patients who achieved CR after chemotherapy or PR, or they were the patients who had stable disease at that point of time. Because losing a patient who achieves CR after completion of chemotherapy is difficult to sometimes take up. But again, immunotherapy is a kind of drug. There are very less side effects, but whenever they happen, and they happen sometimes. They are very serious. So we have to be on the toes. We have to be on the toes when we are giving chemotherapy. But I generally do, the patients who comes from periphery, I give them Isolon tablets with them. And told them strictly, you will use only when I will tell you. Otherwise, you won't use. So because those patients are not going to come back to me if they are living far behind. So they will go to their normal doctor or clinic, and he will not be able to understand that this patient is having some cytokine storm or something like that, or pneumonitis or maybe myocarditis. So I personally feel because we have kind of infrastructure which is not up to the mark as Western countries, when we are giving maintenance immunotherapy, we have to be little bit more conscious. I'm not saying don't give, but be very careful. Follow-up should be very good. What I do is every 7 day or every week I call the patient and tell everything is okay now. So that's what I do personally when I put the patient on immunotherapy, because I know my patients are uneducated. There is not much of awareness in the community regarding immunotherapy. For us, it's a new drug. So I always give them some Isolon tablets along with them. So that's what my perspective. Otherwise, it's a wonderful drug. It's a practice-changing drug.
I fully agreed with Dr. Amit's views. So the first is the early separation of the curve. There is a very good hypothesis actually. There are a lot of comments or letter to editors after the publication of this trial in NEGM. So if you go carefully among the these comments, that there is a very important phenomenon of hyperprogression. If any immunotherapy trial, there are few 5 to 10% of the patients who will be hyperprogressors. That is true for melanoma trials, that is true for NSCLC trials, and that is also true for second line bladder trials also. But surprisingly, for this first line maintenance avelumab data, there is very early separation of the curve, and it is very much parallel separation, not like a means zigzag separation. So that again highlighted the issue or the fact of hyperprogression is totally non-existent for avelumab if you use it after 4 to 6 cycle of platinum backbone. That is one thing, one point which theoretically I want to share in this platform. Just like when you raise the issue of the early separation of the carbs within first 3 to 4 months. That is very important point. And regarding the second point, the 2 patients who died, actually, I have tried my best to explore further. What we can say is this not due to immune-mediated side effects. So immune-mediated side effects happen in 7% patient grade 3, no grade 4, grade 5 immune-mediated side effects. So reason for death of these 2 patients out of 350 patients in the avelumab arm, which is very means less 0.5%, I believe. So one is due to sepsis from urinary tract infection. For an advanced urinary bladder cancer, that can be non-related, directly related to the drug. Second one is after the last dose of avelumab, almost 105 days, patient died due to ischemic stroke. So this is also again maybe not related to this drug, but at least these 2 patients died due to not immune-mediated side effects. That is, we are going to highlight. So in this way, we can maybe justify the use of this drug. Thank you. That's all from my side. Thank you, Dr. Amit, for an active discussion, active participation, and giving your views. Thank Dr. Tanmay
Thank
also,
you, sir.
who left. Yeah. So back to organizers.
Thank you, sir. Thank you very much for a detailed discussion. I hope there is no question from the audience. Sir, I have one question from both of you. Sir, that if a patient is platinum ineligible, then what is, as it's we all know that is a very aggressive disease. So how you manage this patient?
Platinum ineligible basically due to very poor renal function. Usually the creatinine clearance is less than 30. As per the approved recommended regimens, chemotherapy cannot be used because monotherapy gemcitabine or monotherapy taxane can be used, but having a very poor response. So until unless you add platinum, there is not much response with conventional chemo agents. So as per the international guidelines, you can use atezolizumab monotherapy or pembro monotherapy in these populations, but both these drugs are approved as a means one of the arms in the Keynote 361 or IMvigor 130, which showing a much inferior result than the platinum based backbone. The issue is for a platinum ineligible patient, the option is not there. Much options are not there because only monotherapy non-platinum agents in the form of a taxane or gemcitabine will not give you much response. So at least for a immunotherapy drug, if we use, 25% of the patients will have means long-term disease control, but otherwise for the rest of the 70%, the survival will be very dismal because in any way the platinum ineligible subpopulation is a poor subgroup of this advanced metastatic and very poor, difficult to treat disease.
So thank you. And the second one is that as we all know that as per the avelumab data that after the chemotherapy, if patient is on the CR, PR or SD, then we can go for the first line maintenance with avelumab. Sir, is the data means outcome of avelumab will be the same for these 3 type of the patient if we can resect them differently like PR, CR or SD?
Yeah, so that we have discussed. There is a subgroup analysis that showed that for a CR or PR, the survival parameters are absolutely same. For a stable disease, the PFS will be same, but overall survival is somewhat lower than CR or PR. But overall, statistically, this difference is not much. And again, this subgroup analysis is not very important to me because this trial was not sufficiently powered enough to give the answer to this whether there is a real difference in overall survival depending on the prior chemotherapy response, CR, PR or ST. And moreover, this subgroup analysis, the stable disease population was much lower than the CR and PR. So again, there is issue of low sample size for the subgroup analysis. So my answer will be, as per the subgroup analysis, there is no real difference. But again, this subgroup analysis is not statistically powered enough to give the answer to this question. To really get the answer of this question, we should have a different trial designed as per the predefined stratification endpoints of CR, PR or ST and followed by a randomization.
So thank you very much for your time, and I will hand over this stage to Vishwamitra for the vote of thanks and closing of the meeting.
Thank you for this platform.
Well, sir, I have no words to appreciate this. What can I say? This was a academic feast for each one of us who have attended this meeting. I'm really very thankful, and on behalf of Pfizer. To all the faculties, and we had 22 live audiences who had listened to this talk through HiDoc platform. So I'm thankful to all of them. Wish you all a very good night, and thank you for attending this meeting. Thank you.
Thank you so much. Thank you so much, sir. Thank you.
Thank you and good night.
Good night.